Hello, good evening, and welcome to this evening's JCN Live. My name's Alec, I'm MD of Wound Care People, and tonight I am proud to say we are joined by Gillian Mould, who's the Clinical Strategy Manager for ConvaTec, and Joy Tickle, Independent Nurse Consultant, Tissue Viability. Joy, Gillian, are you there?
Yeah, welcome. Hi, everyone.
Well,
hello.
Excellent. So thank you very much for joining us. For those of you who joined us last night, you'll know this is slightly different to our regular Facebook Lives. We normally run around 13 face-to-face events up and down the country. And this year, for obvious reasons, we haven't been able to do it. So we're bringing you all of the content we would have been delivering at those events over the next, or over 3 nights. We had 2 sessions last night, 2 sessions tonight, and 1 session tomorrow. Tonight's session is Exudate Management, Effective Dressing Selection. And this is brought to you in partnership with ConvaTec. So I'd like to say a huge thank you to ConvaTec for supporting us throughout the year and supporting the education that we provide for free to yourselves. So thank you very much, ConvaTec. I'm going to hand straight over because I'm aware that we need to make sure that we use all the time properly, and I need to make sure that I'm not talking too much like I normally do. Certificates will be available at the end. As always, please comment and question. I'll be back with Joy and Jill for a live Q&A after the presentation. Enjoy. Over to you, Jill.
Thank you, Alec. So, good evening, everybody. I would just like to start this evening's session. My name's Gillian Mould and I'm Clinical Strategy Manager here at ConvaTec. I've been with ConvaTec for 5 years now. My background is 32 years in the NHS prior to that, and the last 11 of those before I joined ConvaTec was actually in tissue viability background in North Lincolnshire. Joy, who I believe you all probably know and recognise, is an independent nurse consultant, 37 years experience in the NHS, with 27 of those being in tissue viability. So this evening's session is on Exudate Management and Effective Dressing Selection. And I would just like to thank you all for joining us this evening. I know there's probably Christmas cards and Christmas trees you could be putting up, but great that you're here to look at this very important part of wound management with us. So, Exudate Assessment and Management. So, Exudate, it's a generic term given to fluid produced by chronic wounds and acute injuries once homeostasis has been achieved. It's a slow escape of liquid containing water, electrolytes, nutrients, inflammatory mediators, white blood cells, protein digesting enzymes, growth factors, and waste products. You know, all of that going on in that Exudate, you know, whenever you get a wound, whenever you're looking after a patient with a wound, you know, that there's all that really clever stuff going on. You know, when you lift up the dressing and you see what's going on, you know, so it's obviously, you know, really important that we do, you know, some of that stuff is good for us, you know, Exudate is normal and we wouldn't be without it, but some of it, especially when, you know, it gets into copious amounts, can be quite damaging. It is released from the blood vessels as a result of inflammation and is a normal part of the body's defense mechanism. So here we've got a wound progression Exudate volume curve. In a healing wound, Exudate production generally reduces over time. In a wound that is not healing as expected, Exudate production may continue and be excessive due to ongoing inflammation or other processes. You'll see here on the left of the slide where you've got that necrotic tissue type, you're not going to get large amounts of, you know, no Exudate or minimal. And then at the other end, when the wound's granulating and going into epithelialization, you know, that's when you get reduced in Exudate. But in this middle aspect here, where the curve is really high, that's when you know, in that sloughy state, you might have a wound that's got infection or biofilm. And we know biofilm exists in a large proportion of our hard to heal wounds. That is when wound Exudate becomes a problem for us, and you need to look at something that's going to absorb that, that Exudate. So the importance of Exudate, it prevents the wound bed from drying out. It aids the migration of epithelial cells as they leapfrog across the wound surface. It carries essential growth factors. It supports autolysis. You know, wounds with a moist environment heal more quickly than those that dry out and form a scab. And Swayze does, in fact, you know, report that moist wounds heal 2 to 3 times faster than dry wounds. So, wound exudate needs to be delicately balanced to optimize the wound healing environment. It is all about identification of the wound and patient-related factors so that treatment plans can be tailored to suit that patient. It is worth mentioning at this point that, you know, wound healing may not be the outcome or the goal here. It might just be to manage the patient's, you know, quality of life and you know, and make it a little bit better for them. Often overlooked when we're dealing with complex wounds. There is no such thing as a universal dressing that will absolutely sort everything out. You know, there is no dressing at this present time that will do that. But the dressing that you do pick, you know, we've got to look at what's going on that wound. We don't want to desecrate or macerate the wound. As you can see here, the wound on the left is quite dry. The wound on the right is moist. We've got evidence of maceration on the wound edges with that white boggy skin. So causes of excessive exudate, you know, the inflammatory response, wound infection, you know, heart problems, edema, venous hypertension, and sometimes, you know, people's, you know, blood levels are all over the place. That's why it's so important that we do actually make sure that you do a full holistic assessment to make sure that those patients are getting everything they need, that you're looking at absolutely everything that can maybe help you manage that excessive exudate. So consequences of excessive exudate, as you can see here, this wound in the middle, you know, that's really not very nice for anybody, is it? If it was you or I or a relative belonging to us, you know, that wound is a circumferential leg ulcer. You can see there that the dressing is not coping with the exudate. We've got excoriation and maceration that's even going down onto the foot. So as we can see, the top bullet point here is that it can cause maceration or excoriation, which is evident from this picture. It can cause the wound to break down or break down even further, which will delay or prevent wound healing. Obviously, like I've already mentioned, quality of life is massive for patients, and that is definitely going to impact on their quality of life. And for you guys, you know, that have joined this evening, you know, an increased demand on the healthcare resources. So assessing wound exudate, it can be produced in various types of consistency, colour and quantity, depending on the wound. High viscosity will be thick, quite sticky, could be residue or infection. Low viscosity will be thin and runny, you know, could be a result of those, you know, heart problems, malnutrition, or it could be, you know, those little lymphatic fistulas that we see. Colour of the exudate, do we bother about it? Is it important? You know, how important is exudate colour in our assessment? Do you document exudate colour? Would you know what each colour can indicate? The answer for you is that yes, you should be documenting, you should know what each colour means. So straw coloured serous fluid is considered normal, but beware of your lymphatic or urinary fistulas. Yellow-brown exudate may be due to the presence of wound slough, liquefaction of necrotic tissue or possible infection. Red-pink exudate may suggest the exudate contains blood cells, possible infection, you know, or even traumatic dressing removal. That is why it is so important that if you're using a dressing for the first time, you know what it is that you're, you know, why you are using it. What are you hoping to achieve from that wound? Is it suiting that patient? You know, is there a certain way to remove that dressing? You really need to read the instructions for use in your dressing packs. You should not be putting a dressing on or removing a dressing that you are not familiar with. For instance, hydrocolloids, you know, they don't just get ripped off, you have to take them off in a certain way. So it is very important that you remember all of this. Cloudy, exudate, milky or creamy indicates the presence of fibrin strands in response to inflammation or infection. You know, that exudate can be quite purulent. Green, I don't think I need to tell any of you, you know what that'll indicate. It could be a Pseudomonas aeruginosa infection. I think for most of us that are familiar with this colour exudate, it's quite fluorescent in its appearance, and we can actually smell it probably before the patient's even, you know, you've even seen the patient's wound. Grey-blue exudate can be as a result of using certain silver dressings. Again, very important to read those instructions and make sure you know what you are expecting from the dressings that you are applying. So, quantity. Wound types that produce high and low volumes of exudate. The high volumes will be your chronic venous leg ulcers, your surgical wounds that have dehisced, malignant and fungating wounds, burns, inflammatory ulcers like rheumatoid or pyoderma, and skin donor sites. On the other hand, your low volume of exudate is your necrotic wounds, your ischemic arterial wounds, and your neuropathic diabetic foot ulcers. Quantity, describing exudate levels. So I do hope that nobody uses plus to document exudate levels. It's not measurable and it's not really appropriate in today's nursing. I will hold my hand up and say that in my past nursing years, my early years, I have used this because it's what we did, but not just for exudate. It probably was more for pain and things like that. You know, you should never really be using those that documentation now, and hopefully all your wound assessment charts that you fill in will have exudate levels and the colour and everything on there so that you can follow them. So low, medium and high, minimal, moderate and heavy, non-scant, moderate and heavy are all, you know, good words that would hopefully be able to say to somebody else who comes along and looked for that patient what you saw when you did that last assessment. You can see here there's a little cartoon of two men having a bit of an argument about what they're looking at. One's saying it's a 6, the other's saying it's a 9. So again, that really just brings home to us the importance of accurate you know, documentation and accountability. Really, we really need to be able to be clear and concise in what we're writing. The World Union of Wound Healing Societies consensus document and their best practice statement do advocate using dry, moist, wet, saturated or leaking. As you can see here, the wound bed, when you're documenting if something's dry, the wound bed will be dry, the primary dressing is unmarked. Moist, small amounts of fluid visible, primary dressing may be lightly marked. Wet is small amounts of fluid visible when dressing is removed. Primary dressing is extensively marked, but there is no strike through to the outer dressings or bandages. Saturated, primary dressing is wet and strike through is occurring. Peri-wound skin may be macerated. Leaking, honestly, as you can see here from these pictures, you know, the dressings are saturated, the exudate is escaping from the primary and secondary dressing onto the clothes and beyond, you know, the floor, the bed sheets, the carpets. Dressing change will be required much more frequently. I have had patients turn up at the clinics I've worked in before with, you know, with wounds like this, and it is really unacceptable that you see patients like this. You need to make sure that partnership with the patient is so they're given all that education. They know that they should need to know that this is not acceptable. You know, they need to know if they've got anything like this, that they're giving you a ring. You can either see them or visit them a bit more regularly, and, you know, and things like that, because it is not appropriate. You need to do a reassessment, you know, another holistic assessment, and see what are you putting on, what's changed with this patient if it's new that this has developed, and really try and, you know, look at everything again and see what you can do. So exudate management, you need to optimize the wound bed moisture level, manage the symptoms, which hopefully will improve the quality of life. The surrounding skin is really, really important. It needs protecting. We need to consider factors influencing exudate levels like debridement, infection and biofilm. You know, are you managing that patient? You know, your local management means, you know, what kind of dressings are you putting on? Are you looking at everything that could be contributing to that problem? You know, negative pressure is a possibility for a wound that is exuding quite heavily, and fluid collection devices are available as well. I mean, I haven't used them a lot in my practice, but I have at times, say for a sinus, on a hip, for instance, had to put, you know, a colostomy, you know, ostomy bag on, you know, on that to try and protect the peri-wound skin and to make sure that you know, we can monitor and see what's going on with the exudate. Where excessive exudate is a problem, or where exudate composition is suspected of impeding healing, your priority is to remove that exudate from the wound bed. Dressings are the main option for managing exudate at wound level. I know there's simple dressings, there's multi-layered dressings. I get that it's a minefield for you. You know, a wound care handbook with, you know, 368 pages telling you all about dressings. You need to refer to those for guidance. You need to refer to your local formularies for guidance, because that will tell you what kind of dressings you can use on what kind of wounds, and make sure you're referring where needed if you are uncertain. You also should make sure you understand how a dressing functions, and that will assist you in making the appropriate dressing choice at that time for that patient. This is where your company representatives really come into play. You know, really listen when they're telling you about the dressing so that you know when is it appropriate to use those products. Optimizing the wound bed. At the end of the day, wound healing, you know, is about moisture balance. If the wound is too wet, we need to absorb the exudate. If it's too dry, we need to donate moisture. You know, it's just about getting that equilibrium, and we're always striving for that. All dressings will fit, you know, that are on the market today will fit onto these scales at some point. It's just up to you to try and work out, you know, where it is. So for instance, if you've got a wound that's too wet, you need to make sure that you're going to remove the moisture, you know, not just remove it, but take it away and keep it away. You know, the dressing needs to retain it, and sequestration means that, you know, it needs to stay where it goes into, that it's not spreading out on the wound. You know, you're suspecting, you know, do you need to debride that wound? Is it a dressing that's going to debride as well as manage the exudate? And if I suspect an infection, you know, is it a dressing that can treat that infection as well? The sorts of dressings that you would use for a wound that is quite wet is your hydrofibers, your alginates, your foams, and super absorbents. And obviously not on this list, but already mentioned, is negative pressure. A wound that's too dry, you're needing to add the moisture. That's when you use your hydrogels, your hydrocolloids, and your films. So sometimes a dry environment is optimal, though, we know that. I mean, you're not going to try and debride these wounds that we can see on the picture. You know, you've got ischemic wounds, patients that are immunocompromised. The focus for these is to prevent infection. And also, you know, in the pressure ulcer guidelines, it is recommended, you know, that we keep, you know, this heel pressure ulcer, for instance, is actually the body's natural defense mechanism. And you just need to, you know, see, obviously sort the pressure out, but basically, you know, just let that evolve. So considerations, you know, you need to make sure, you know, you're considering, is the dressing vertical wicking, which means it mirrors the wound and it's not laterally spreading out across to damage the peri-wound skin. You know, is it absorbing and retaining so that you're preventing lateral spreading, so that fluid's being forced out? And that's what you can see on the right hand side. But again, you know, it might be that that wound suddenly just started exuding a lot and causing damage to the peri-wound skin. You know, you may need to do another assessment, do a combination of dressings, or possibly, you know, increase your nursing visits for that patient. So what do we need from a dressing? Just to reiterate, we need to manage the absorption, retain, take it away, keep it away, protect the peri-wound skin, because that is very, very important. And we need it to respond. That wound might have nooks and crannies in, you know, it might have an infection. You know, is that dressing that you've got on there going to fit to the wound bed? And is it going to respond to any infection that you're wanting to deal with? So the summary from me this evening is exudate production is a normal feature of healing wounds, but when the exudate produced is too much, too little, or of the wrong composition, a wide variety of problems can occur, ranging from psychosocial issues, you know, those quality of life issues, delayed healing and infection. Careful attention to contributing factors and local management can help to reduce the likelihood of problems, encourage healing, and avoid unnecessary health burden costs. So thank you for listening to me, and I'm going to hand over to Joy now. Thank you.
Thank you, Jill. That was really interesting, and effective exudate management and exudate per se is something I feel really passionate about. I'm now going to continue this evening discussing with you what effective exudate management looks like in clinical practice and how we can safely combine evidence-based wound dressings for effective outcomes. Now, we hear a lot about evidence-based practice. We know it's crucial in today's world of wound care and healthcare to ensure, as you as clinicians, you're safe and accountable practice, healthcare providers for their, you know, accountable and legal practice, but not so for me, for the patients, to ensure that safe practice for them. Today, certainly we need to be reporting clinical outcome measures. And I will ask you in the audience this evening, how many of you are aware of your organisations or your services that actually record and report outcome measures of the wound care interventions you put in place? If you don't know, do ask, because I really think, from around evidence, we should be recording these. We should be looking at what our outcome measures are. If I'm seeing a patient in clinic for 3 months, I need to be aware, and certainly if I'm providing that treatment, what are the clinical outcomes for the patients? What are the clinical outcomes for the organisation? And, it may not necessarily be that we've healed 20% of wounds by week 4 or whatever. It could be that we've improved the patient's quality of life, and it's important we record that. Economical drivers, we are under enormous pressures in not just in the NHS, in all healthcare providers, and we want to ensure quality care, but we also need to ensure, of course, it's cost effective also. So we talk about evidence, we have lots of evidence, different forms of evidence, but despite this, we see the frequent use of wound dressing combinations without evidence or certainly without a clear clinical rationale of why we're implementing that treatment combination. And that can have a detrimental impact on the patient's wounds. And frequently I have asked clinicians, why are we using that combination? And sometimes we haven't got that clear rationale of why we're using that dressing combination. And so what we tend to see is multiple dressings upon one wound, and often referred to as the sandwich effect. And very frequently, I've seen wounds with not just 2 dressings in place, which is normally common, a primary and a secondary dressing, but 3, 4, sometimes even 5 dressings in situ. And I'll give you an example of that. One patient I saw who had iodine on the wound bed, then an alginate dressing on top, then a superabsorbent dressing on top of that, then a charcoal dressing to assist with malodor, and a retention dressing on top of that. So again, how do we know those dressings are going to work in combination? How do we know what contradictions may happen if one is injuring the other? How do you measure clinical outcome measures? If the wound is not improving, which dressing is it that's causing a problem? We don't know. And in that instance, we are using products off license, and certainly we need to think about our accountability in our clinical practice. So what are the effects if we get the decisions wrong? And I know we don't aim to get the decisions wrong routinely. None of us are set out to harm our patients, but the consequences of getting decisions wrong regarding effective exudate management and combination dressings can be like the picture you can see on your screen. The patient and it was a patient of mine who presents in clinic with certainly, as you can see, that excoriated wound bed where the skin's become eroded, and that waterlogging effect, the white effect, where the skin and the tissues and the cells have become waterlogged. And that's because the exudate has been left in contact with the skin and the wound for too long a period, or it's not been managed effectively in a short period. Now, as Jill said, exudate is a natural process, it's a natural part of wound healing. It's a good guy. It's only bad when it's not managed effectively, because it will contain waste products, it will contain irritants and enzymes which will cause further damage. And you can see that leads to wound deterioration, delayed wound healing, increased risk of infection because the more moisture, the increased microorganisms, increased pain, increased pain, poor quality of life for the patients when they're suffering with leaking, pain, smell, malodor, causing them to become very anxious and socially isolated. On top of that, for you as clinicians, you're going to have to be changing these dressings more frequently, increased time restraints, and also increased time restraints for the patient also. And I know, as I've said, as clinicians, we are constantly striving to find the right dressings to manage the patient's wound, or whether it's a simple wound or a complex wound. So again, we are always striving to find it. And frequently we do use some combinations of dressings, but sometimes there appears to be very little consideration, as I've already said, given to their compatibility. You can see the image on your screen, multiple small wounds with multiple different dressings. What is your clinical rationale here? What is the reasonings for the use of the dressings? And again, is there any evidence as to the clinical effectiveness of using them together, or are we using them as a new product? So this made me reflect on my own practice and the practice area that I work in, and it made me consider, you know, I do use dressings, 2 primary dressings, sometimes where there is limited evidence, and I have to rely on knowledge and clinical, my clinical experience. But sometimes that's not enough, is it? We do need that evidence, and I would prefer to use evidence. I prefer to use 2 primary dressings if there's evidence, because then I you know, it's reassurance for me, it's accountability for me. So, you know, it made me think about that a lot in my own practice. And I was reading around evidence, and it came to light. I was reading a paper on that was released by ConvaTec on perfect partnership. Sorry, that's a lot of P's. And with the perfect partnership, they looked at a study using 2 primary dressings with supporting evidence of the clinical outcomes of using them together. And I was very familiar with the Aquacel family and confident with their evidence. So I decided myself to undertake my own evaluations. Now you might say, well, the evidence is there, Joy. Why do you have to take out your own do your own evaluations? Well, I like to do the evaluations to look at the clinical outcomes locally for our patients, and also look at staff experience and their clinical outcomes when using the products as well. So I did a small study, and I followed the patients up with the wounds, followed them up for 4 weeks or 20 dressing changes, whichever came sooner. Now, outcome measures that we evaluated and included was, of course, wound progression. So we looked at the wound size, the wound depth, the wound bed tissue type itself. We looked at the levels and volume, the levels and types of exudate. We looked at the peri-wound skin condition, the patient's pain and comfort levels, the frequency of dressing changes, and then the overall dressing performance compared to the previous dressings used. And obviously time limitations this evening won't let me go into all of the details of the outcomes, but I'm going to share some key points with you. In all of the cases, the wounds progress to or towards healing, and that goes without saying. The improvement in the quality of life for the patients, the improvement in the clinical outcomes. In all cases, the peri-wound skin improved or remained healthy, and I will say this is one of the key factors for patients. The peri-wound skin damage causes them significant pain and discomfort, and by just improving that, or certainly not causing any problems with it, meant it was an increased improvement for the patient. But for me as a clinician, and for the clinicians I worked with, it meant that we weren't going to get new wounds developing due to skin problems or the wound itself deteriorating. And I think a lot of those factors for the improvement in the surrounding skin was because the exudate produced from all of those wounds was managed effectively with the 2 dressing combination. Importantly, patient comfort. All of the patients reported excellent or good comfort when the new regime was put into place. And again, that goes without saying, if a patient's more comfortable, they will sleep better, they'll become less anxious, they will eat better, all contributing factors that will support and encourage wound healing. And then the patients themselves would have confidence in the treatment and have confidence in you, because they can see the wound improvement, they can see the improvement also in comfort. Frequency of dressing change reduced in the majority of the wounds, or remained the same in just a small proportion, but it certainly didn't increase. And that reduction in the frequency of dressings meant improved quality of life for the patients. And I know I keep talking about it, but it is so important. Less dressing changes, less pain if there was potentially a pain, but also patients who attend clinics, patients who work, patients who are waiting for a community nurse to visit. You know, the less frequency of dressing change improved their activities of living and the impact on their everyday life. For clinicians, we're already overstretched, we know that. So busy wards, busy teams, busy nursing homes, you know, this is going to release time for you to care for those patients that need more of your time. And so overall, using the combination of the synergy of dressings with that evidence, as you can see, all the wounds progressed to healing. all cases, it was improved dressing performance. 93% of the peri-wound skin improved or remained healthy. Dressing changes reduced dramatically, and all cases the exudate was managed effectively. Most importantly for me was the patients reporting of improved quality of life scores and certainly making changes to their everyday lives in practice. And it made me also think about, why did the two dressings in combination, why were they so effective for various reasons? And you can see on your screen that slide about the different combinations and properties within that combined primary and secondary dressings that give you those real such good clinical outcomes and improve the patient's quality of life. But I don't want you to take my word for it. I want you to, yes, always look at the evidence, learn further about that evidence, about this, the evidence around the use of the dressings in combination with robust evidence. Take the word of my two patients I'm going to share with you. Now, this lady was 54 with a venous leg ulcer. She also suffered with anemia. Now, these are contributing factors that may cause an ulcer to develop. Even anemia can lead to skin damage, and prevent wound healing, or did certainly delay wound healing. She was a smoker, again knew the dangers, and she worked, and she had 2 children, and she was married. But on assessing the patient, we're not just assessing the wound, are we, in the limb? We're assessing the patient's environment, we're assessing the patients themselves. What is the impact? We really need that real good patient-clinician relationship to understand what this means to the patient. And this lady often said, you know, frequently referred to herself as not normal, as, you know, not feeling like a mother or a wife. And it really did lose her, she lost her confidence and she was anxious, all because of the wound and the non-progression. She'd had previous treatments and she'd had lots of antibiotics and antimicrobial dressings over many, many months. And, you know, we really have to be mindful of really strict antibiotic and antimicrobial stewardship in wound care. And she continued in compression therapy. The treatment we implemented was just really good effective cleansing and debridement, which was the case. So preparing the wound bed, removing and reducing the amount of microorganisms, removing any, breaking down any biofilms present and preventing them reforming. We in this instance, due to local infection and the presence of biofilms, introduced Aquacel AG plus extra dressing as the primary, and then a foam dressing, the Aquacel foam dressing with that the second layer of Aquacel hydrofiber also. Continued the compression system, and you can see the improvements. Now, the improvements were the primary dressing, of course, could come in contact with the wound bed. We assume that all wounds are flat. They are not flat. All wounds will have small contours and small gaps. And we need to make sure those gaps and that dead space is covered with the primary dressing. So the primary dressing can contour and fill those dead spaces, and the primary dressing in this case could do that. It promoted autolysis, it helped to reduce the bacterial burden and prevent the reformation of the biofilms, and then helped to whip the exudate into the secondary dressing, where the secondary dressing could lock and hold the exudate, prevent the exudate's negative factors. So let's remember, exudate's good. So good moisture balance, prevent those enzymes and irritants from causing further skin damage. And this lady could then move on to self-care as an option, where she could, because of the ease of application and the evidence of using the two dressings together, she delivered her own self-care with compression therapy hosiery. And you can imagine how that led to increased independence for her. And finally, my final patient was the 62-year-old gentleman. You can see from the picture he has 2 significant ulcers, which are tracking. He has hypertension and diabetes controlled on insulin, and he also has peripheral vascular disease, all contributing factors to the potential amputation. And this was a big fear factor for this man, as you can understand. It was a big fear factor for us as clinicians also. He was a smoker, and despite knowing the problems associated with peripheral vascular disease and reduced wound healing, he continued to smoke despite support. He has children, grandchildren, and a wife. And you might say, why are we adding that in again, Joy? Because it was the most crucial things for this gentleman was to get back to walking, to get back to seeing his grandchildren and attending once a week with his friends to play dominoes. And to him, yes, we all thought his big risk factor, you know, fear was losing his foot. Yes, it was. But he wanted to resume what he called his normal life. Previous treatments, he had a successful angioplasty, I will say that, and he'd had surgical debridement with success, and there was no osteomyelitis. But again, this gentleman in just 4 months had had numerous courses of antibiotics and antimicrobials. So again, effective treatment was a real good effective cleansing, debridement and biofilm implementation, which we'd already done. Because of the cavity, because we couldn't see the wound bed base itself, we needed to lightly pack this wound, so we have the option of using the rope. So we use the Axel AD plus extra rope as well. It could contour into the cavity, it could absorb the exudate, it could promote autolysis, all those factors we said about it. It could mold into that area and could easily be removed. We applied an aquacell foam dressing, so again the exudate could be absorbed back into the aquacell, into the foam dressing, and be locked away and prevent any further damage. He continued to wear his offloading foot device, but can you see in 8 weeks a vast improvement in a patient that was a high risk complex wound as well? And for him, you know, the less frequency of dressing time for him meant, you know, he could obviously undertake not being restricted at home. He could undertake seeing his grandchildren more often. For the clinician, it meant releasing time to care, as we said. The clinician said they were confident in the combination, dressing combinations, and confident with how the wound was improving. And the patient reported he was confident in the clinicians, and that goes a long way, doesn't it? Having that good joint confidence in both the treatment and the clinician as well, and prevent that further risk of infections and possible amputation goes without saying as well. So in summary, really, combining dressings together without considering compatibility, yeah, it is common practice, and combining dressings that have no evidence to demonstrate how they perform together, it may not always give the best clinical outcomes, and we need to consider, you know, all the issues around accountability. I hope that the clinical evaluations and the small clinical study and case studies demonstrate the effectiveness of choosing 2 dressings designed to be applied together. And it's not just about that, is it? You know, I think we do have to think about dressings used in combination. We do have to think about how they will interact. So it's important that we have the most appropriate dressing to deal not only with the wound type, but with exudate as well. And if we have to use a dressing combination, which in most cases we do, don't we? Make sure it's a combination that will work in synergy. And as wound care technology improves, quality wound products have been demonstrated to be more cost effective in the long run. They're more cost effective in the long run because they are reducing clinicians' time. They're reducing and preventing wound-related complications, reducing healthcare providers' resource costs, but most importantly, improving the negative impact to the patient living with a wound. So I'm now going to hand over back to Alec and ready for our live Q&A. Thank you.
Thank you, Joy, and thank you, Jill. Fascinating presentation, as always. And there's lots and lots of questions that we've had come through. So I'm just going to go straight to them. So question number 1, which is for you, Jill, is you spoke about some wounds that need to be kept dry. Can you tell us more?
Yeah, I mean, I think I mentioned most of them in the presentation, but, you know, your ischemic wounds, you need to be very cautious because, you know, there's a poor blood supply to those patients. They're obviously maybe under a vascular surgeon, they've been referred, you know, so again, it is just about making sure that you're looking at everything to do with that patient, that you've assessed them properly, and that, you know, you're doing that full assessment to make sure. You've also got your wound fungations. Again, these are very delicate wounds that need to be really, really cared for. Some fungations and malignant wounds are really dry, some are really exudous, some can be a mixture of everything going on all at once. So again, it's about finding that right dressing, you know, that you're going to put on that wound that's not going to do any damage, because these wounds, the fungation and malignant ones, can bleed actually quite heavily. So again, and then you've obviously got your end of life patients, for instance. What's your outcome going to be there, really? Do you want to go in all guns blazing with advanced dressings, try and debride? It's about making that patient's quality of life. And that's what I said about the end goal might not always be to heal. You've got to look at your patient and see what kind of things you're doing for them. I don't know if Joy wants to add anything else.
No, Jill, no, that is absolutely spot on. I think you've got to, it's not just about the wound, is it? It's about the patient, it's about the patient's choice, their dignity and all the other factors. And there are times that, the most important thing is certainly ensuring a really good quality of life for these patients with these types of wounds.
Yeah, thank you both. And it is probably worth pointing out, because you just mentioned it, Jill, that a lot of the wound types were mentioned in the presentation, and the slides will be available to view again and to download from our website from tomorrow afternoon. So you'll be able to have a look at the presentation in your own time, as well as rewatch the video and share it with your colleagues. Question number 2 for Joy: what is the best advice for cavities that are wet?
Right. Well, I'll take a step back. Gosh, I'll put my teeth in tonight, Alec. Take a step back. With cavities, you've got to know what you're dealing with. So yes, it's a cavity, but what is going on underneath that cavity? So before you even start thinking about dressings, make sure you're working as a team, and it may be with other MDT team members. So, are there any tracking areas? Is it a sinus? Is it tracking anywhere? We need to be working closely as a team with this. If it's a cavity and you don't feel there's any areas tracking or sinusing off, then you, of course, need to loosely pack that, and packing, you don't overpack. And I know it's very subjective, how much packing do you apply, but it's loosely packing. What we want to do is fill the dead space, which is what Jill and I have both said. So you need to fill the dead space. Ideally, the best way of doing that is, but especially if it's heavily exuding, is with a rope type packing, where it can contour into the dead space, it can absorb the exudate, and it can whip that exudate, that free flow of exudate into the secondary dressing as well. So if we're talking heavily exuding cavities, then I would say, your best form is looking at a rope type, like the hydrofiber type dressings that can gel in contact with the exudate and contour and fill the dead space.
Cheers. Thank you, Joy. Question number 3, probably for the two of you, but for you first, Jill, if you don't mind. This is from John. This is, what would you dress necrotic toes with bloody exudate coming from the demarcation site?
Oh. Yeah, I had a picture of a wound very similar, I think, on my presentation. And again, it's really difficult at times to know what's the best thing for those. But again, those are the patients that I mentioned that you need to keep free from infection. So you are probably going to be using an antimicrobial, most definitely, but also one that probably isn't going to adhere, because again, that's the worst thing. If you can imagine, you're trying to take a dressing off that's sticking. Some dressings can be pre-moistened to prevent adherence. But again, I think Joy's already mentioned it's about quality of life as well, not to be overlooked. Just think how scared that patient's going to be to know that probably they're going to wake up and the toes are not going to be joined to the body anymore. It's about making sure that, they've got all the information, that they know probably what's to expect, and that you are, as well as a clinician, John, did you say, I think you asked the question, that you've reached out to the multidisciplinary team. I don't know, Joy, anything else to add?
I think no, you're right. I agree with everything you said. I'm not going to disagree with Jill. I would if I did want to. No, I think the thing is, and the bloody exudate, I think John mentioned, that bloody exudate, and it can be just a part of the natural autolytic, where the body's trying to debride and amputate the toe itself. But the other thing I would look out for, and Jill, you were right, you possibly would use an antimicrobial there, because if that is an indicator, that bloody serous exudate is a sign of clinical infection, we really don't want that patient to become systemically unwell as well. So yeah, I think like you, Jill, I possibly would put an antimicrobial dressing on as well. The aim isn't we aren't going to heal it. What we're trying to do is prevent that risk factor for that patient, which is that risk of systemic infection, really. And as Jill said, with patients with these complex wounds, you've got to be talking and have a really good, open, transparent dialogue with your MDT team and your patients, of course, and your patients, family and carers who are your eyes and ears when you're not there as well, to know what to look out for.
You probably want something absorbent, but that doesn't wick too much, I guess, because you never really know where that blood's coming from. So let me, we're going to wrap up for now. However, we've had loads of questions that we haven't been able to get to. So what we're going to do is, as always, we'll download all of the comments and all of the questions and share them with Joy and Jill tomorrow, and then we'll create a document with all of the responses, so that we do actually get back and answer all of your questions. So keep an eye out on our website. That should take, it's usually a couple of days or something like that. No pressure on Joy or Jill, but it depends how long they take to send us the answers back. So we'll get that up. There should be a link now available on your screen to download the certificates. I'd just like to thank ConvaTec again for supporting this evening's event and for supporting us throughout the year. Jill, Joy, well done for a wonderful presentation. We'll be back in about 15 minutes time with the second session. So you've got time to go and get yourself a cup of tea or coffee, maybe a quick bite to eat, or even a glass of wine. But we'll be back with Rebecca Elwell talking about chronic edema at 8 o'clock. To join us for that, you just need to log out of this, click on the cross to close the video, and then you'll see the live stream in a couple of minutes ready for the next session. I'll be back then. For those of you who will not be joining us, have a good evening. And for those of you who are, I'll see you again in 15 minutes. Goodbye all.
Bye. Bye. Good night, everyone.